Well, welcome everybody. Thank you so much for joining us today. We have two special guests that are just coming back from Colorado. I'm Catherine Ibarra. I'm one of the clinical education directors here at Banner Health, and I'm going to be interviewing Lindsey Stewart and Jessica Flake today. They are just coming back from serving up at NCMC in Colorado, where they help take care of our patients that have coronavirus or COVID-19. And we're going to learn a little bit about their experience and ask a few questions and just get a better insight for what we can do in Arizona. Ladies, thank you for joining us today. Lindsey.
Thanks for having us.
Yeah, Lindsey and Jessica, do you want to go ahead and introduce yourself? Lindsey, you can go first.
My name is Lindsey Stewart, and I work at the Heart Hospital in the CV ICU. That's my story.
Jessica, you want to introduce yourself?
Hi, yeah, my name's Jessica Flake. I work in Banner Baywood 7th floor neurostroke PCU.
Awesome. So thank you for being here. Thank you for your service. Can you give me, Lindsey, a little bit of a description of how the units are functioning up there in Colorado?
Yeah, so in their ICU, they have like their normal ICU, and then they have an overflow ICU, which is actually like normally a PCU, and then they have their burn ICU. So the burn ICU is kept clean, so no COVID patients over there, but they had like a nice like overflow unit, and then lots and lots of other overflow units. That's like if they needed to set those up, they were there.
Mm-hmm.
Fortunately, we did not have to do that. But it was, I think, when I was there, when we were there, it was, I want to say close to 38 ICU beds. Every patient, 38 ICU rooms, and then we had rooms that were doubled. So we had more than one patient per room. I'm not sure what the census was, but so we were taking care of two patients in a room, even though they were single rooms. The setup was pretty crazy. Rooms were totally cramped, but when I was leaving, it was definitely, we were starting to make more of our rooms single rooms again, which is a good sign. But the way that the teams were set up was you had your nurses, so you had your ICU nurses that were primary care providers for the patients who were positive with COVID. Then you had a bunch of ancillary staff, most of whom were also nurses, but nurses from like endoscopy or cath lab or IR. We had labor and delivery nurses. We had EMTs. We had flight nurses. So we had just this like huge group of people that were around and assigned to you to help you. So the biggest thing was to limit PPE usage. So you would go into a room and you had your helping hand person be your runner. So you would go into a room, you would do your morning med administration, your care for your patient, and then you would kind of just like scope it out and see if there's anything else that you needed. Like let's say like you forgot a medication, your helping hand would go and get that. So that was set up that way. There was always help, like always help. It was pretty insane, actually. I've never worked anywhere where I could just poke my head out and have someone available to get me whatever I needed. So there was that. And then you had, I wouldn't say it was a turning team because, we were just grabbing nurses and we were grabbing like staff members when we could. So we had people that would come to, like, we would be like, okay, so we would talk to the doctors in the morning. We're like, all right, we do need to prone this person. Let's get a time set for whenever we're going to prone them. And then you get like your group of 5 or 6 people plus your respiratory therapist, and you would prone your person and you would leave them prone for 16 hours. So you had a group that you would always have, that you could always count on to come and turn your patient for you, or not for you, but turn your patient with you.
Right.
And so it was just, like I said, this like well-oiled machine in a sense that like you had a team around you at all times that you could rely on and you could count on to help you do things that you kind of take for granted in the ICU experience when you're not caring for your ARDS patients with COVID right now. So it was really great. And I mean, when we first got there, it was not we were still working through some kinks, but then it was like every single provider, every single nurse, like everyone was just all on the same page, and it was like, okay, we're going to do whatever we need to do to make sure that these people get better. And we have had a lot more successes than I would think failures at this point, which is good. I mean, we're still seeing failures, but I mean, we all have to look at the numbers and see that what's amazing is that I do think that Colorado's numbers are better than everywhere else's. And I don't know if that's because we have more staff and more I don't know, like not necessarily PPE, but like we're doing everything before I think it gets bad.
Right.
Or at least we're trying to do everything before. Yeah, exactly. It's proactive.
Wow, thank you so much for that insight. Jessica, I'm going to ask you this next question. Can you describe the type of patient that you were caring for? What does, COVID-19 look like from a nurse's viewpoint in the hospital?
Yeah, so I'm actually working in the COVID unit at Baywood, and I can tell you there's a significant difference between the patients that I'm seeing here in Arizona and the patients that I'm seeing in Colorado. It seems like the Colorado patients are just more sick, and I'm not sure, if it's maybe because we just haven't seen that influx of COVID patients yet. But yeah, I mean, they would just decline significantly over there in Colorado. And we would try to keep them from being intubated because the concern was always, do we have enough supplies to be able to provide the patients when they're intubated. And so the nurses on the PCU floor would have 3 patients. And it was just, we always had so much anxiety because we're trying to keep them on, like, not being intubated. And, these patients, they're so sick. There's only so much you can do, and they decline so fast within a few hours. Like, I would come in on a shift with a patient on, like 2 liters nasal cannula, and in the shift with 15 liters.
Wow.
Like high flow, so it's just, or like non-rebreather. It's just really, really, it was difficult over there because it just seemed like they were so, sick. And over here, at least, I haven't seen that too much, which is really good, but also makes me very nervous, just because, like, the way that they were doing things over there in Colorado, I feel like they definitely, like Lindsey was saying, at first it was a little bit harder, because they were still trying to figure things out. But definitely towards the end of my time there, they had a lot more figured out, and people were working together to take care of these patients. So I really wanted to, like, kind of bring that over to Arizona because, I feel like we don't see a lot of it right now.
Right.
And that just makes me concerned that it's gonna, like, come, hard and fast, and it's gonna end up being like Colorado, where we're like, oh my gosh, what are we gonna do? So definitely, like, yeah, from what I've seen over there, like, the patients, they just required so much time and attention. And I never, at least personally, did not see a patient able to go home without oxygen. Like, they're always ending up going home with at least a little bit of oxygen when they only required room air, when they came in the hospital. So
that is interesting. Wow. Okay, Lindsey, so how long were the patients staying in the ICU?
Oh, man. Okay, so we were seeing patients in the ICU for a minimum of 8 days, as long as 28 days. These patients, like, it's not like your typical ART. They need so much time, and, like, they're so fragile that if you even just change one certain thing while they're intubated, it could just, like, set you back days.
Oh.
So, like, it's going off of what Jessica is saying. Like, these are really sick patients. I have worked in places where I've taken care of really, really sick patients. And this is nothing like I've ever experienced before. It's not just the common cold or the common flu.
Right.
These patients are just, they're so sick and they're so fragile. And if we do one thing that is wrong, regardless of how well they're doing, we could just set them back. So minimum of 8 days in the ICU, and then upwards. Like I said, I know of one case in particular where a gentleman was there for 28 days, and I think we did end up sending him home, thankfully, but he was on the ventilator for 28 days.
My goodness.
So yeah, they're very, very sick.
I'm glad to hear that he ended up going home, though. That's a relief.
Yeah.
Jessica.
Yeah, it's one of those. Oh, sorry, go ahead.
No, go ahead.
I was just gonna say, it's one of those things where it's like everyone is really sick and we are seeing people die from it, but I think the deaths are kind of overshadowing the people that are getting better. Like when we were there, we had our 100th patient sent. Like last week, it was the 100th patient that was sent home after surviving COVID, and so it's like, that's amazing.
That's the beauty in it. Yes, the survivors.
Yeah.
Jessica, what were the common treatments that you were seeing prescribed to these patients?
Well, they were all on Plaquenil.
Okay.
So we would always have to monitor their QTC interval. At first, they were doing like Q24-hour EKGs, and then they kind of backed down from that, and then we kind of just, the nurses would do their strips and kind of like measure out the QTC.
Okay.
So they were all on that. They were definitely all on oxygen, and proning was a huge thing too, intubated or not. Like if the patient was declining, like proning as a form of increasing their oxygen saturation was one of the doctor's like main go-tos. So I did have also a lot of patients that weren't intubated at all, but still proned for as long as they possibly could be. So, but I think, from like a PCU standpoint, the Plaquenil is what they were basically basing on to help with these patients. And I know a lot of them also were on azithromycin in addition to Plaquenil. I'm not sure in regards to like an ICU standpoint if Lindsey has anything to add in regards to treatment.
Yeah, so from the ICU standpoint, so we would get calls about patients who were either declining rapidly or who came in on 55% on room air when they hooked them up to an O2 stat probe. We would immediately intubate those patients, or we would bring them downstairs to the ICU from PCU, and we would intubate them. And so the rationale is the earlier the intervention, the better the outcome, and I 100% agree with that. So if they came in and even though they were like just barely short of breath, but we hooked them up to the O2 probe, we would intubate them. Like it wouldn't even be a question. And then so what would be started is we would do the Plaquenil, which they're doing a 10-day course. We would do azithromycin, which azithro is 5 days, and then we would also do Solumedrol, and those two are both 5 days. So azithro and Solumedrol are a 5-day course. We would do all three of those, so the triple therapy. Azithromycin, we would give them a 500 milligram dose the first time and then drop it down to 250 daily. And the Solumedrol was, I believe, 40 milligrams daily for that as well. And then the Plaquenil, we would start out with a higher dose the first time, and then we would decrease it. And just like kind of going off what Jessica was saying, we would prone our patients, like depending on what their oxygen requirements were on the ventilator. Like I think it was if they had a PEEP higher than 14 and oxygen requirements greater than 70%, we would prone them for the 16 hours overnight and then flip them back in the morning. And we even, we would actually prone patients after we had extubated them just to kind of make sure that they weren't going to decline, or we wanted to prevent it, because it's not like just because you have it once doesn't mean you're not going to have another bout with it, like,
Right.
or it doesn't mean that it's not going to come back in full force. Like the first patient that I extubated, his question, one of the first questions to me was, "This can happen again, can't it?" And it's like, yeah, it can. Like, that's why we have to be proactive. I know the other day someone had asked about paralyzing. So the patients on PCU, obviously you can't paralyze them when they're prone, but in the ICU we have to. We have to paralyze them when we prone them, because they're so thick that we can't have them fighting the vent. So we would do, obviously when they're intubated, they're on like your sedation, so your propofol. Then you have like your pain control meds, so like fentanyl. We would also potentially do, like, depending if the person couldn't tolerate propofol, we would do Versed.
Okay.
So we would do some things differently, because I mean these patients needed that, and then they would always be paralyzed if they were prone. I did not see a single person prone, intubated, and not paralyzed.
Okay.
That was definitely something that we did. So
great insight. Thank you so much. All right. So how about, we kind of talked about the treatments that you're seeing, and then what was working best. The theme I kept hearing was proning. And we hear a lot about the manual proning. We're prepping for that in Arizona. Why do you think that's so impactful for the patient?
in regards to proning, it helps with movement of lung secretions. So when you think about it, if you're laying on your back, your secretions are just going to pull, and they're going to block the alveoli at the back of your, or at the base of your lungs, and it's just not good for you to just kind of be stagnant. So when we turn the patient over onto their stomach, or when we prone them, those secretions are mobilized, and it's a good way for us to kind of give those areas of the lungs a break. And I think that was like the biggest rationale. And I know in normal ARDS, that is a treatment that we use a lot. I mean,
Yeah.
we have specific beds called rotoprone beds
Mhm.
for patients who are in ARDS. But I mean, obviously we don't have enough rotoprone beds for the numbers of patients that we're using. And personally, I like manually proning better than the use of the beds. I mean, you get a team together, and you just, it's like I said, well-oiled machine. You get a team together, you have someone holding the airway, and you just flip that person. And it's insane, actually, because you'll hear lung sounds when the patient is supine, but when you flip them onto their stomach, you can hear lung sounds much better, and you get a lot more secretions up because we're moving them and we're mobilizing that. And it's just better. It's better for their lungs. It's more surface area for their lungs to oxygenate. It's awesome. It's an awesome method to help the patients.
Thank you so much for that insight. Yeah, that's what we're hearing. The key is to prone. So in closing remarks, what do you think we can do in Arizona to best prepare for what you saw in Colorado?
I mean, people need to stay home. That's a big thing. One of the biggest groups of patients that we saw in Colorado were from a meat packing facility, and they were giving incentives for them to go to work, and then it was a huge outbreak of COVID, and these patients came in. So definitely stay home for sure. And then just like from a hospital standpoint, I think starting the triple therapy early, so the solumedrol, the azithromycin, and the Plaquenil early, if it's able to be started early, would be good for these patients who we feel are COVID positive. Chest CTs are very good. I know that in Colorado they were kind of leaning towards just doing a chest CT and starting the triple therapy before we even got the COVID results back, because it was just such a clear way to diagnose it, even though the tests weren't back yet. So, and then proning early, even if they're not intubated, just prone the patient, like they were doing in PCU, and even after we were extubating patients. So the earlier the intervention, the better the outcome, for sure. And I feel like that's kind of how it is for a lot of things.
Yeah, absolutely.
But definitely the earlier the intervention, the better the outcome.
Jessica, how about you? Any closing remarks?
Yeah, so I just think, to prepare, we should definitely, just talk to our sister banners and see, what they're doing. Just because, especially like in Colorado, they do have more experience with COVID patients, or at least the ones who are sicker than we do as of right now. So I feel like, just talking to them and, getting insight on, what they are learning and what's working best for them, just so we don't have to, not know what to do and be confused. Right. And like, it would just make things so much easier in the case that we do get that big influx of COVID patients. And then, obviously everything that Lindsey was saying, kind of, I definitely feel the same, like, proning early, and all those other interventions early, and definitely just obviously staying home and listening to that. Actually staying home and taking it seriously, because it is serious. And I know a lot of people still kind of are, they're like, no, I don't think that, it's that big of a deal, but it is. There's a reason why, we are quarantined in our houses right now. It is definitely a big deal. And I think, in order to prevent spread of this, staying home is so very important, and monitoring yourself and making sure that you are staying home and staying away from people, but definitely in order to prepare for if we do get an influx of COVID patients, I definitely just think it's so very important to kind of learn and mirror off of what other hospitals are doing.
I 100% agree with that. Definitely. The physicians, like the 4 intensivists that we worked with in Colorado, were incredible, and they were all on the same page. And that's another thing too, like our physicians and our providers have to be on the same page for a treatment plan, because you can't have someone come in and change everything that we just did for a week's time. So definitely, like, talking to the physicians at Northern Colorado Medical Center, definitely, and just learning from other, like, one of the doctors just kept saying, he's like, this is what we're doing here. He said, I don't care what everyone else is doing. He said, but this is what we're doing, and it's working. And he wants everyone to know that, like, he will gladly talk to whomever about treatment and preparation, and just like, because I mean, it's so new for everyone, but definitely, it's just talking to the physicians at Northern Colorado Medical Center for sure, because they have a great thing going. I really do think that it was just, it seemed to be getting so much better throughout the time there, with their level of preparedness and the plan that they had set in place. So yeah, definitely just talk to them to prepare and see what can kind of be expected here.
That's one reason I'm so thankful for our leaders at Banner Health. They do such a good job of connecting those dots. And, they took you guys from Arizona with your experience, and they took you to Colorado to help out. And they are going to absolutely tap into those intensivists and make sure we all have the best treatments across our system. But thank you so much for your bravery and your courage, and for going to Colorado, and truly being that hero on the front line. Lindsey Stewart, Jessica Flake, it is such a pleasure to talk to you today. I thank you for all your insight, and
thank you.
I really appreciate
thank you.
Have a great day.